It's now my pleasure to introduce our speaker for today, Suleima Salgado. Suleima is the Director of Telemedicine and Project ECHO for the Georgia Department of Public Health. With over 15 years' experience in state and local government, healthcare education, and public relations, she has led various public health initiatives in both Georgia and Florida. As Director of Telehealth, Ms. Salgado manages a $2.4 million budget and is responsible for setting strategic goals to increase access and bring health equity to underserved areas of the state through collaboration with Georgia's 159 county health departments. Suleima works daily with state and federal agencies, health systems, county health departments, private providers, public schools, colleges and universities, and nonprofits to develop and implement telemedicine programs across the state. Ms. Salgado holds a Master's of Business Administration from Southeastern University in Florida. She also serves her community as a Rotarian with the Rotary Club of Gwinnett, is a member of the Georgia Hispanic Chamber of Commerce, and is on the Medical Reserve Corp Georgia Emergency Management Response Team, and she serves as a board member for Mentor Evolution and the Gwinnett Coalition. Suleima, thank you for joining us today, and at this point, I'll turn it over to you.
Thank you so much, Sherry, for that introduction. Give me all just a moment to share my screen and we will get started. I appreciate you all having me today. I'm very excited to share this presentation with you. It's a little different than my usual presentation since it's not specifically around telemedicine, so I'm very excited. All right, and let me put it in presenter mode. I'm also going to stop my video just so it doesn't distract you all as I present. All right. Again, thank you so much. I'm Suleima Salgado, the Director of Telemedicine and Project ECHO for the Department of Public Health. And today I want to talk to you about something different outside of my usual, Project ECHO, and really how we work to build workforce capacity of healthcare workers across Georgia, specifically through our Department of Public Health. Many people always wonder, how does public health play a role with ECHO community? And what really is ECHO? So my goals for today is really just to do as such. My learning objectives is to help you all understand our Department of Public Health specific initiatives aimed to improving healthcare equity through our Office of Telemedicine and Project ECHO. I'd also love to describe with you all our Project ECHO initiatives and give you a little bit of an overview about those, and really share with you some data collection from these initiatives that we've seen since 2019 as we build our Project ECHO initiatives through the Department of Public Health. I always like to say that I have no financial disclosures. So it wouldn't be me if I wouldn't give you a little bit of background around our telemedicine program before talking about Project ECHO. And really that is what has led us to implement Project ECHO through public health. As many of you know or may not know, we have a very robust telemedicine program through public health. It started back in 2003 as a state pilot program where we implemented telemedicine services in specific rural districts throughout our health departments. And that kind of morphed into a formalized statewide network buildup through one of our previous commissioners' times, where we formalized telemedicine as a statewide program out of our state office, and we started implementing it across all 159 of our county health departments. In 2016, we built our formal statewide telemedicine network through public health, specifically for our public health patients and public health staff, where we had dedicated circuits. And we made sure we had adequate bandwidth so our health departments and specialty clinics could receive and provide telemedicine services. During that time, we were fortunate to receive a $2.4 million legislative appropriation to the Department of Public Health to fund our telemedicine infrastructure, really allowing us to carry out our public health mission and really serve those in those communities. As many of you know or may not know, broadband continues to be an issue, and it really was one as well for us through public health and our health departments. Many of our health departments were not able to run their electronic medical records and do clinical flow while also providing telemedicine services, given poor bandwidth connectivities. So we were very excited to be able to build that. We leverage various web-based platforms to provide clinical services through telemedicine through the Department of Public Health, and those are Pathways and WebEx. So given that we had this expansive telemedicine network, many of our clinics were familiar with providing clinical services over video conferencing. We thought, well, how cool is it if we start working on a Project ECHO initiative and really looking at more leveraging our web-based technology for that telementoring, kind of distant learning meets workforce development. And we stumbled upon Project ECHO out of New Mexico, which is what I want to talk to you guys about today, where we really focus on building that capacity and knowledge among urban and rural care providers. So we knew we were providing clinical services, but we really wanted to do some of that mentoring for clinicians and look at our provider side. So we thought ECHO was a perfect fit under our Office of Telemedicine. And for those of you who are not familiar, Project ECHO stands for Extension for Community Healthcare Outcomes. And really what that means is it's helping us move medical knowledge and not people and develop specialty care capacity in underserved communities. So again, think about distant learning mixed with telemedicine meets kind of a lunch and learn type thing, where we are using and leveraging providers in urban areas and even in rural areas to be our core team to share that knowledge to other providers and clinicians across states, across counties, and share that knowledge so that they feel that they have the capacity and the tools that they need to collaborate and be able to better serve their patients. I'm going to share with you just a brief little video to see if that kind of gives you a start to what today's conversation will be like.
Every day, around the world, people suffer and die from diseases we know how to treat and cure. We created ECHO to solve this problem. I'm a liver disease specialist, and in 2003, there were very few doctors in New Mexico treating hepatitis C. Patients waited 8 months and traveled hundreds of miles to see me, and I was only able to treat a tiny portion of patients who needed care. People were dying, and I knew had they been treated earlier, lives would have been saved. The challenge was to treat all New Mexicans, even in the most remote and underserved areas. That's how ECHO was born. We created a knowledge-sharing network which used video conferencing to mentor and support doctors and nurses across the state. Over time, they became great experts. Patients received care in their communities by their doctors, and the wait in my clinic fell from 8 months to 2 weeks. At its core, ECHO empowers people with the knowledge and support they need to reduce human suffering. With our global network of partners, we have replicated the model for 40 other disease areas in 16 countries. Our goal is to touch the lives of 1 billion people. With your support, we can ensure that the world's most vulnerable benefit from the world's best collective knowledge.
So I hope that allows you to get just kind of a big picture of where we're going. So empowering, building knowledge workers, and kind of growing that knowledge across various sectors. So Project ECHO actually launched in 2003, as you just heard, out of New Mexico. And Dr. Aurora is a social innovator and a liver disease specialist at the University of New Mexico in Albuquerque. And as you saw, he was very frustrated that he could only serve a small amount of people. So he wanted to serve as many as he could, very similar to what we do in telemedicine. And so he started this mentoring group of community-based providers to treat a condition. And since then, Project ECHO has boomed. So again, if you didn't hear and quite get it from the video, how it works is we're connecting those providers with specialists through ongoing interactive telementoring sessions. Very similar to what we're doing today, but there's a little more formality behind some of it, and there's some didactic presentations. So what we're doing is using low-cost, multi-point video conferencing technology to conduct these sessions with various community providers, where all the specialists serve as mentors. We work together to train our community of providers to care for patients in clinical areas that was previously outside of their expertise. So we know that in Georgia, we have so many rural communities. We know that there's so many rural hospitals, and a lot of these physicians and clinicians in rural communities kind of feel siloed and feel alone in their communities. So the goal is for us to be able to make sure that they have a trusted community that they can reach out to for questions, concerns, feedback, and just to know that they're not alone in these communities. That way, we're also building knowledge and helping them share so that they can better treat their patients. When you're looking at this ongoing mentoring, the spokes, which is kind of the distant sites, as many of us call, outside of the hubs, they also gain that specialty expertise and knowledge. And since the initial expansion of ECHO started out of New Mexico, This model has been replicated across the United States and across the globe. And you can see the impact numbers here. So every echo is very unique based on specialties, and we'll talk about that. We'll also learn whether or not CMEs and CE credits are offered, which in many echoes they are, and then very unique partners across the states and across lines to help that educational piece. So many always say, okay, well, why ECHO? Why isn't it just a distant learning program? Why isn't it a lunch and learn? Why isn't it a webinar like we're doing today? And it's a little different. So when looking at ECHO, you're really looking at it from different aspects. So you're looking at the patient, you're going to look at your community health worker, and you're going to look at the provider. So let me give you an example. The problem. We know that underserved patients have limited access to quality specialty care for many complex conditions. So what do? We build this model that expands access to care by leveraging telementoring and guiding practice to build the system. And we empower those physicians to help care for those complex conditions. Many of you know you go to your general doctor, and then your general doctor refers you to a specialist, and then that specialist refers you to another specialist. So how cool would it be if we know that in certain areas and underserved areas, there's only a general physician who, while they might have practice and experience in multiple subjects, that's really not their subject matter expertise. And they would prefer to refer you out to a specialist, but that specialist may be 2 hours away, 4 hours away, or 6 hours away. How great would it be if that clinician was part of an ECHO community where they could learn and continue to practice, but also learn and have educational experience in other specialties so that they could become subject matter experts. And while they're referring you out for services, they'll still be able to give you a lot more insight. So here's an example. In 2003, if you see from here, only 5% of New Mexicans were infected with hepatitis C were able to access treatment. By 2015, 80% of New Mexico's infected with hepatitis C had access to the right treatment at the right time and at the right place by leveraging ECHO and building that workforce capacity. So what's the benefit for a provider? Pretty much the same thing, which is a little bit of modifications. So why do providers want to ECHO? Well, you of course want to advance your skills and careers and professional relationships. There's a huge lack of access to knowledge and training provided for specialty care for their patients. And often they just feel socially isolated, as we've talked about. So why not engage in ECHO, where they have a community with like-minded fellows who are very interested and they come from different academic centers. They can work to develop that specialized knowledge and then provide that specialty care for their conditions. On top of that, we all know that we're always looking for some CMEs and CE credits. So to receive free CME credits through these initiatives while also learning is great. And as you can see in that example, so providers participating in ECHO out of New Mexico felt that their personal isolation diminished, their professional satisfaction increased, and this was specifically around the first hepatitis C initiative. So when you see that more than 76,000 free CMEs and CE credits have been issued based on their initiative. Same goes for community health centers. We look at those community health centers and we understand there's limited ability to provide that specialty care for those common complex conditions. And as we all know when we're experiencing because of this pandemic, it's very difficult recruiting and retaining community providers. Given your community in which you live, it could be access, it could be resources, it could be schooling, it could be the cost of living, and it could just be the salary. But knowing that when you build and you hire a staff member and you want to help them grow, you want to build the capacity for them and provide them the extra tools and resources that they need while making them feel at home. And that's really what the ECHO community has done. These health centers really help expand access to care for chronic conditions, but they work together collaboratively to recruit and promote and retain those providers because they are confident and they know that they have a community in which they're working within. We could talk a little bit about the ECHO benefits. And as we've talked about already in just these past couple of slides, the benefits from ECHO are enormous. From just under overall better access for rural and underserved patients to know that they are being treated by the best of the best and continue to have resources available to them, from reducing health disparities, looking at the overall quality and safety, looking at best practices, and greater efficiency. Project ECHO's model has really been recognized not only statewide, but nationally, and has been awarded over 20 major grants since 2003. Now, this is at the high level, does not even include local state grants and other grants that have been throughout the country. When looking at national partners, such as the Department of Health and Human Services, the Department of Veterans Affairs, the Robert Wood Johnson Foundation, and the GE Foundation. Accomplishments for ECHO have been recognized also by the Heinz Family Foundation, the American Telemedicine Association, and the Distant Learning from the United States Distant Learning Association. And I think that's also really important to know. ECHO does a great job at really being clear and making sure that you understand that there's a difference between telehealth, telemedicine, distant learning, and Project ECHO. So now that you know a little bit about just general Project ECHO, let me tell you about the work that we're doing through the Department of Public Health. As you can see on the right, these are the 7 active ECHO clinics that we currently offer through our agency. From infectious disease to hepatitis to stroke, cancer registry, maternal health, the diagnostic treatment and cancer staging ECHO, and our palliative care, which is our most recently launched. When we started Project ECHO, we were the 2nd state Department of Health to ever implement ECHO across the nation. And that was in 2019. And we started with infectious disease. Back in 2019, actually, there was an ECHO-like pilot prior to that was unsuccessful through the Department of Public Health. When the program tried to launch it, they didn't have any agency resources. They had no community buy-in. It was way pre-pandemic, so telemedicine was kind of coming up in conversation. Video conferencing was starting to become a more common thing. But there wasn't a lot of buy-in around the kind of formality behind ECHO. ECHO certifications also were kind of expensive. There wasn't a formal marketing promotion for ECHO, and it was slowly finding its way. But then we started growing and continued to expand. And that's when we realized that by going through the formal ECHO certification process through the University of New Mexico was going to open a lot of doors and opportunities for us to really standardize what ECHO needed to look like. And they provided us marketing, education tools. They also provided us some curriculum to help us get started. And for us, our initial goal was really just to unite the Ryan White Part B HIV community in discussing clinical updates and client cases so that those infectious disease providers and clinicians felt less isolated. We also wanted them to have a safe space to ask questions and grow professionally. We joke all the time about how heavy Department of Public Health is in preventing and helping patients with infectious diseases. But many of you don't know that across our state, there may only be a couple dozen infectious disease providers that provide service. One of our infectious disease doctors actually covered 13 counties alone, making it very difficult for him to increase the number of patients that he saw. And it really took a lot of time and energy from him from going from county to county to county to see patients. He also felt kind of isolated because he was on his own. So knowing that there was a community in which he could reach out to and work together and collaboratively, he could also build workforce capacity within his clinics has truly helped him and the community. For us, our success for implementing this initial clinic and many of the others was really just knowing that we had the video conferencing infrastructure already in place through our agency. We knew that our staff were familiar with it. We had state leadership support and leveraging cross-collaboration tools. And then when we realized that COVID-19 and so many staff were working remote, there was less in-person meetings, there was less opportunity for continuing education. Many people were feeling isolated. It really helped us kind of ramp up our efforts and really put a focus on that educational learning and cross-collaborative learning. So now that you saw the different services that we offer, the different types of clinics or sessions that we offer through ECHO, I kind of want to share with you how we collect this data and kind of how ECHO data is collected. So for us, through the Department of Public Health, we kind of use a basic Google form where all individuals participating in ECHO can register individually and their health center information, and they just use the Google form and sign up. It's a very basic form. It asks you questions and answers such as your name, your site, what type of provider you are, a clinician, credentials, etc. And from there, we also leverage our Cisco WebEx reports. So after meetings, we're able to pull back attendance records that has email, the exact length of time you connected, the connection type, whether you were on your phone, whether you were on a tablet, or you were on your laptop. Was it just an audio joining only, audio and video? So it's really how we kind of collect our attendance. We also have a lot of participant submissions. So during our ECHOs, they're intended to be very interactive. There may be a presentation first where a staff member or employee or a team member gives just a presentation. And then we start looking at case presentations, and we really look at those didactics. And then we actually have case presentations where we discuss cases in details. Where they're de-identified cases, any of the clinicians can present one in advance, and we sit there, we review it, we analyze it, we discuss the session, we discuss the patient, what happened, treatment, medication, what could have been done differently, what were health risk factors, what's the follow-up plan, and they're able to ask all those questions. Again, all de-identified. And during those sessions, we also are able to look at our overall timing of those sessions. How long did these sessions last? How many questions were included? What were outcomes? And there's even follow-up if needed. If a case is reviewed and not completed, we're able to follow that up in the next and following sessions. So when looking at this data, we're able to pull attendees per session. And this just gives you a snapshot of all of our data through December of 2021. Again, 2019 through 2021. You're able to see our infectious disease sessions where we had the number of sessions were 33. When we started and launched that ECHO, the average number of attendees per session, the total number of registered attendees for all sessions, and then any anonymous attendees in those sessions. And we'll get into a little bit more about how those are identified and how people are categorized. Now, it's important to note that ECHO sessions are not intended to truly be these elaborate, huge, webinars where there's hundreds of participants at a time. Now, they can be, but remember, the goal is really to share, to learn, to discuss. There's a lot of Q&As back and forth and discussion. Average ECHO sessions are about 12 to 15. Given COVID, that's increased a little bit to about 20 to 25. But really for us, 12 to 15 is kind of our baseline. We are very pleased so far with the numbers and the results that we've seen. Again, intended to be a learning community where you're able to share and work collaboratively. Now I'm going to stop just a moment just to see if there are any questions before I get too far into the data, because I didn't think to do that. And if not, I'm happy to answer questions at the end. But Sherry, do you mind just doing a quick check for me and letting me know if there's any questions in the chat already?
Sure, I don't see any questions at this point, but I do want to remind everyone, you have access to the Q&A panel. Please feel free to submit your questions and we'll answer those throughout the presentation. Thank you.
Perfect. All right, I will continue from there. So when looking at this information, and what I didn't share is that the ECHO provides a database for you to report all of this data and where all this data is captured. I didn't mention that in my previous slide, and I totally failed for that. There is a platform called IECO. And in that IECO platform and database is where all your individual kind of registration information is housed. And our core team pulls the information off those Google documents and inserts it manually into IECO. Many IECOs across the state, or many ECHOs across the nation, allow individuals to register on their own through IECO to participate. But public health, we decided initially that we wanted to manually enter the data for each individual registrant so that we had clear data, because it is very sensitive to kind of how you put your information, how you identify yourself, what type of provider you are, where your health center location is. So for us, we wanted to make sure that there was some consistency, so we had good, clean data. And I will say I'm very thankful for my teammate, Jackie Woodard, who takes time out of her day every single day to go through our requests and look at the number of registrations in ECHO and enter that information manually. To date, we have 607 contacts in IECO, meaning they have registered, they've identified themselves, and they are in our ECHO database. And that is representation from 21 states plus one Ethiopian city, which is huge to show that, Georgia is implementing ECHOs with such a big influence. So we are very excited about that. So when looking at these slides and looking at that average attendance, again, when you're looking at some of them and you notice kind of that fluctuation of up and down and zeros and nothing there, when you're looking at that January through March data right here at the bottom, we had not started any ECHO sessions yet. So that's why they are at 0 and the numbers are so low. And then when you go back here and you look at June, that was a session that was canceled, whether it was the presenter wasn't available, they had an issue, staff differences, etc. So you can really see our growth and as sessions progress. So when you start an echo, you slowly start working to build that community, you kind of peak, things happen, you see the holiday schedules, you see different things going on. So you can really judge your average attendance. You can really see some of the other ones that really start off slow, boom, hit a peak, kind of have a slow lull again, and then they increase. And it's really your responsibility as an ECHO team to kind of build and continue to foster those relationships so that your numbers continue to rise and or stay the same. But again, it could be based on content, it could be based on subject, it could be based on staff resources. When looking at these specific echoes based on their type, even our infectious disease echo, we know that there is a lot of staff turnover in a lot of our health districts when looking at that program and looking at that implementation. So making sure that we are constantly recruiting and engaging clinicians and physicians to join is really important for us. Now, when you look at these, you start seeing that overall participation and the number of attendees as well. Now, this one's just 2021, but I find it very interesting to kind of just see that lull, that wave again, up and down and up and down. And for us, while it goes from high to zero to up to zero, it's because not all echoes are the same dates and times. So for us, the cancer registry that you see in that green, they don't meet every month. So there are some months they have 0 attendees because they're not having a session. And that is something that ECHO, and based on your communities and your type of clinics, you need to determine. Is this something that you want to do monthly? Is this a session that you do bi-monthly? Is this a session that you do weekly or every other week? Again, based on your participants, based on your subject, you get to decide how frequent your ECHO sessions are. I will say it is very important, and ECHO recommends that you are very consistent with your dates. So if you're doing it monthly, it could be the 3rd Thursday of every month, and the time is for you to determine. So if you do it the same way, it'll be 3rd Thursday of every month from 12 to 1, or the 1st Friday of every month from 7 to 8 a.m. Your decision. And that is kind of how we work with our programs to build their echoes based on their registrants and their participation. Now, who's participating in the DPH echoes? And we find this kind of data very interesting, and it's so helpful for us that IECO ask these questions. You can see the type of specialties and who participates in the echo, whether they're physicians, they're pharmacists, advanced practice registered nurse, social workers, CMAs. Now, I will give a disclaimer, though, that all this data is based on registration info submitted by the individuals. So if they categorize themselves in an area, that's kind of where it puts them. I also want to make another disclaimer that this data is not required in order to attend echoes. So there is probably a good number of people that are missing. You can attend an echo session as a guest and just hop on and participate without formally registering. And that is something that we stress a lot as part of our echoes when working with our core echo leads, is to remind everyone in their sessions that, hey, once you've attended a couple echoes and this is a community you want to be a part of, it is very important for you to register so that we're able to capture your information and know what the impact is. So that is just something that I always want to reference there. It's also very interesting to see for us on our back end, and there's discussions always around like, well, if you're a physician, how are you ranked in here? Like ECHO automatically comes you under the physician category or the pharmacy category based on the data you entered. So we're always really curious to see kind of what that means. And then others, when you look at it, you could be under, if you're just a public health employee and you don't fit under any of their categories, then you kind of get lumped into that other category, which we wish and sometimes wonder how much more we could break that down. But we're only given certain databases and fields to use, and that's kind of how we leverage. And then when looking at the cases and didactics, you can really see how many case presentations. Now, ECHO really encourages case presentations. This isn't supposed to be just a traditional lunch and learn, a traditional webinar. The case presentations are key. Now, I will say it is very difficult when starting off your echoes to kind of start off with case presentations. Again, the goal, as I continuously say over and over, I feel in every slide, is it's to build that rapport and foster relationships. So for someone to submit a case that they might have seen, de-identified patient case, you've got to kind of feel comfortable in your environment to be able to share how you treated the patient and then take that feedback and allow for questions and answers from others. So oftentimes we can go a couple months initially of launching an ECHO without any case presentations. And then once those relationships are fostered, or we found a key champion within those ECHO sessions, that they begin launching and hosting case presentations and sharing those case presentations with us. Now, in one of the slides earlier, I didn't mention, I think it was on this one, it was really important to also, actually it's the next one, it's this slide. When you're looking at those presenters on the right column where it shows the didactic and it says, acute stroke has 7 by 3 presenters, it's really important to know that the presenters must also be captured in our IECO database to be considered a presenter. So for example, if let's say I'm on a call, Sherry's on a call, we've got Jennifer on a call, and we're all presenting, if Jennifer and Sherry are not registered in our IECO database, and they're not truly captured in this data as a presenter, and it would probably only just capture one, which would be myself. So it could be a little misleading, and those numbers tend to actually be a little bit higher than what they reported, but we're very glad to at least have a baseline to be able to estimate. So I know that was very broad. That was a very kind of overview of what Project ECHO looks like and how DPH is leveraging ECHO to increase access. And I'd love for us to have plenty of time for Q&As. So I'm going to stop here and just say that my call to action is, if you're interested and you want to be a part of this, join a Georgia ECHO Hub, join our Georgia ECHO Consortium, which is a new consortium that is being hosted by the Georgia Rural Innovation Center. If you do not know Chris Scoggins, please let me know. We will connect you. We are really working to not just be part of the large ECHO community, but to really build a Georgia ECHO community. We know that public health is not the only stakeholder at the table building ECHOs and expanding ECHO. We know that there are partnerships at Mercer, there are partnerships at Emory, there are partnerships everywhere at CHOA. So we want to build our Georgia community and our Georgia ECHO community so that 1, we're not duplicating efforts, 2, that we're working collaboratively, and 3, we're sharing those cross resources and available contacts and really leveraging everything that we have in Georgia to offer. And the Rural Health Innovation Center has been spectacular at helping build this consortium to get us to kind of network and work together. And if you're new and you have additional questions, you're welcome to always reach out to the New Mexico ECHO Institute. But I really encourage you all to join a tele-ECHO clinic that suits your needs. If you want to just join, be a listener and a guest and participate, we welcome that as well. Because from there, once you connect, you're also going to be part of gaining that experience in treating patients with common complex conditions and learning best practices and just kind of meeting a whole new group of friends. This slide shows you all of our contact information. So on the left-hand side, you see our state leadership team. We are small, but we are mighty. We are also currently working on hiring a Project ECHO specialist to help us kind of cross-collaborate with all of our programmatic ECHOs and posting that position. And on the right-hand side, you'll see all of our state clinic leads based on their subject. So if you're interested in joining the infectious disease ECHO, when these presentations are available, we're able to discuss and share with you. All of these programs are on our website, so they can route you to those web pages and have a contact email address that you can reach out to learn more about those ECHOs. But most importantly, if you want to be a part of our ECHO community, you can email us at the email listed below. And we have a team that will respond and make sure you are put into the right group and or contacted by the right individual. And then I also listed a place where you can kind of type down if you want to join our ECHO and fill out the registration form and become a member. We put that email link as well in that website address. So I know I'm down to like 10 minutes, so I'm going to stop there, stop sharing my screen, and welcome questions and answers.
Thank you, Suleima. That was absolutely an excellent presentation. There are a couple of questions that have trickled in. The first I'll ask is urban versus rural participation. And you sort of started talking about at the very end when you started talking about the Rural Center for Innovation and Chris's group. Do you know what the numbers look like? Are our rural providers joining in ECHO, or does it seem to be more of an urban focused participation group?
So there is a mix. We have not been able to pull that data, and that's a good note. I'll make note and see what else we can go back and pull from that. But as of right now, based on some of our ECHOs, we do see a good mix. We see a lot of core ECHO team members being from urban areas, connecting back to rural. And in other specialties, we have a lot of rural providers who are subject matter expertise connecting back and sharing with urban. So there is a good mix. But that is part of your marketing and education piece when implementing ECHO and building your ECHO communities, is making sure that you are targeting both and making sure that you know where those networks are and those contacts. We do hope to work a lot more with the Center for Innovation to help us truly target specifically those rural providers and those rural communities. Again, public health is mighty, we are big, but we really leverage local contacts, our local boards of health in those districts to really help us target those communities. And the Innovation Center is really going to also help us with those clinician access because we don't have a database of all the providers. So we'd love to start working with them and working with some of the other organizations to really increase the awareness of Project ECHO.
Great, thank you for that. The other question is concerning the different types of providers and people who are joining in. It appeared, the question I think goes back to the slide where you had the list of providers and the approximate numbers of each of those professions that were joining in. And this person noticed that seemed to be, there were more nurse practitioners than PAs joining in. And I think the question goes back to, and you sort of alluded to it just now, is that marketing piece. Are we marketing to all of the various aspects of providers, or is it mainly going toward maybe the MDs rather than the PAs and the NPs? Just curious about that.
Yeah, that's a great question. And it definitely goes back to marketing. It's just the audience in which we know who we're familiar with working with. And there definitely needs to be more marketing and education specifically to those PAs so that we can get them more involved. There's just not as many involved in public health efforts currently.
Thank you. And this is just a question I have off the top of my head as we're talking. So you were talking about registering to be a part of an ECHO group. So is it open basically for the general public, or do you have to have some type of qualification to be a part of a group? What does that look like?
So anyone can join an ECHO. If you're curious and you're interested and you want to be a part of the community, again, it's open to the general public. There's never really been a no, you can't join based on your medical expertise or no medical expertise. So yeah, it's totally open. We do like to make sure that if it's a community and we are trying to use it as like, lessons learned and going back and forth, we would love for some medical expertise and not required. Clearly, I am not a medical provider, and we join on these ECHOs in those conversations. So yes, it is open. It's also very important. I just saw a comment, sorry, and I got distracted, but yes, it's also open for medical students and other healthcare related students to join. So we have students that can join, residents who are interested in learning more about ECHO. Absolutely. So everyone's allowed to be part of that conversation. Again, really going back to us, we've started these based on small little groups, targets that we knew were hot topics for our public health staff and workforce. And we started growing from there. I think now we're at this place where we are now comfortable in running ECHOs. We are very familiar with how the database is going. We're familiar with continuing education. And 2022 is really our year to market, promote, educate, and really ramp up the groups of providers and audiences that join. I'd also like to mention, you mentioned about the nurse practitioner versus PAs. Public health is really employed with mostly nurse practitioners, more nurse practitioners than PAs. So that's kind of why those numbers look different.
Okay. And a couple questions they're coming in now. Is it possible to utilize ECHO to help families who are dealing with developmental disabilities and autism spectrum disorders?
Absolutely, yes. We could start an ECHO specifically for those communities in that target. So sky is the limit. Center for New Mexico, University of New Mexico does not indicate what can and cannot be created as part of an ECHO. You, based on your programmatic needs, your audience, and the goals of your state, your local agencies can determine what ECHOs you want to start. As long as you can work together with a collaborative group to build your core ECHO team to build that curriculum, absolutely. So yes, we've already started having additional conversations to expand services into tuberculosis, lupus, chronic diseases, and infant and toddler mental health.
Great. Do you know if there are any fees to either start a Project ECHO or to join an ECHO?
So to join and participate in an ECHO, and specifically through public health, there are no fees. I have not seen there be a fee to join any of the open ECHOs. It's also important to recognize that there are also closed ECHOs. So when you look on the University of New Mexico ECHO website, they have a list of all the ECHOs and where they're located. You'll see some of them might say closed. And that might be because they have a specific audience. They might be a series where you might just have like 12 sessions and you need to do 1 through 12 in order to complete the series. So they're not open, but there is not a fee to participate in an ECHO. There really isn't a direct fee to host and start an ECHO, but there is some administrative services that you might need to secure on the back end. So whether you're looking at staffing to build your ECHO, you might want to factor that in as a fee. And then the University of New Mexico also offers continuing education. So if you start an ECHO and you want to be able to offer continuing education, you would pay that administrative fee to offer that through your ECHO with them. And in addition to that, if you don't have a web-based platform to host your ECHO sessions, the University of New Mexico offers that as well at a cost. So not a direct cost just to get it started, but as you work to implement it, there might be some administrative costs on the back end. And for us in public health, it was very easy for us to just continue to grow again because we already had those administrative costs covered.